here at ATP today. I am going to go over three things. So before I get there, I want to talk a little bit about my story and why I'm here. So I started as a clinician so as Todd already said, my disclosure, I'm Canadian. So I trained in Toronto and did my med school and residency there and thought I was just going to stay there for a long time. Met the person who became my wife, and she's American. And so after being there for a long time, she said, well, 7 years, she said, okay, I want to move back to America. And I was like, well, I don't, so just like some of you may have thoughts about Canada or the Canadian healthcare system, turns out Canadians also have thoughts about America or the American healthcare system. And I was pretty naive and had only lived in Toronto my whole life. So I'm thinking, America, I don't really know much about it. I think if I hit my elbow, I'll get an MRI. But sure, we can try moving there. And didn't know any schools, any places. So had a really short list of places I would agree to move to. And Boston was one of them because I was sort of looking up schools and they had this school in Boston. I thought, well, I want to work there. And they have this large children's hospital, Boston Children's Hospital. So if I can go there, let's just go. So turns out they had a fellowship and it was in part health services researcher. So go get your master's in public health at the School of Public Health and then also do a fellowship that's designed in a clinical area. And I got there in '98. So if you guys remember '98, some of the literature, Bob Wachter had published his term hospitalist, and that had just come out. And so I got there, called up Bob, said, hey, this is actually what I am, because in Canada that's all we do when we train this way, and so I'm pretty sure this is going to stick here. And then for 2 years proceeded to meet a series of people, both in Boston and outside, who told me hospitalists were the dumbest thing they had ever heard of, and it was never going to take off. Okay, so here we are 20 years later. So it's a thing now, which is great, but at the time it was unknown. And so one of the things I learned in my fellowship was, how do you go about proving to people your ideas work and your concepts work? So the studies I did early on in fellowship were looking at the hospitalist model. Does it work? What's it supposed to do? How's it supposed to work? And did 3 or 4, actually we ended up doing 5 studies. I actually worked with a fellow of mine, Chris Landrigan. He's a patient safety expert and at the time had been doing a lot of sleep studies or sleep research on fatigues and how it leads to medical errors in medicine. And so he and I would co-create a bunch of things together. During fellowship, though, I got really interested in this idea of, I don't simply want to do research for research's sake, but how can we do research that can be at the bedside, can change practice theoretically the next day? How do you do that? And so because of our hospitalist work, Don Berwick, who was in Boston at the time he was the CEO of IHI, came up to us and said, hey, I think this work is really interesting. Why don't you guys present at my conference in Florida? It's like a yearly thing. I knew nothing about it. This is sort of like, okay, not totally early internet, but not a lot of people were surfing in late 90s, if you recall. It was sort of slow and take a long time. So I didn't actually know anything about the conference. Show up, and there's a lot of people at this conference. Walk in a room, talk with an adult hospitalist who had done a lot of great things at the Brigham, and he and I did this session together. I presented our research, which had been done. We surveyed all the pediatric chairs in Canada and the US and asked them what they thought of hospitalists. This is '98. We started the survey in September. We closed it in October. We had the results in November. We had 91% respond, which I'm told is a very good response rate because chairs are apparently very busy. And so basically they told us what they thought. And so in December we were presenting this. So I thought, well, research is fast, right? You can just start it, stop it, get the results, and present it. Went into the room, there were 200 people, presented my 15 minutes, very scientific. This is the background, these were the aims, these were the methods, all that sort of exciting stuff. Are there researchers here in the room? I should probably ask. Okay, good. So I thought I was doing all the right thing. All of a sudden, the questions start. I was blown away. Well, how do you decide what to pay them? What about burnout? How do you get them to work only at night? I really want to protect my faculty for the day. Is this really going to be a career thing? And they just bombarded me. And I'm thinking, this is the only research that's actually ever been done in pediatrics on this topic whatsoever. As far as I can tell, this is all we know. And I don't know the answers to any of your questions. Not only do I not know the answers to any of your questions, what's really scaring me is you're administrators and you're making decisions, and I have no idea how you're making decisions because I don't know what information you're basing it on. That was my naive fellow view, okay? So I was pretty disheartened, actually, and I just thought, I don't understand. I thought in healthcare, clinicians, and I was learning about research, we're supposed to provide the information so administrators can make decisions. And it just seemed like it wasn't connected. So very kind of disheartened, went to the keynote speech, heard about this, the speaker stood up, sort of put his arms on his lapels like this, and then started talking about this magical land called Intermountain Healthcare, and how we prioritize care, and then we have these formed teams, and we have these care process models. This should sound somewhat familiar. Then we have data systems to track it. Oh, and we have a children's hospital. And then I'm like, oh, they have a children's hospital? So that was Brent James, and he was giving this speech back in '98 at December, and so I waited in line. So there was this long line of 45 minutes full of people. Oh, rah, rah, rah. And I'm just standing there thinking, okay, well, I'm never going to meet this guy, but I'm just going to wait. So I was the last person in line, and I said, hi, I'm so-and-so, and he said, where are you from? So I told him, and he said, let's sit down and have lunch. So he, of course, hadn't eaten, so he's eating. We talked for an hour and 15 minutes. I was blown away. And he just wanted to know who I was, what I was interested in, what I wanted to do with my career, why I cared about this. And that was sort of the first half of the conversation. I kept trying to he was like, no, just tell me about you. And then he started to tell me about this place. Fast forward 2 years as I'm looking for jobs, or about a year looking for jobs, this is my safety interview, okay? This is my test interview. Why? Because we're in Boston. My wife had her first child, so we were like, oh my gosh, we're parents, we know nothing. And kind of like overwhelmed. And my in-laws live in Boise. So I'm like, oh my gosh, they're looking for, I opened up the back of pediatrics. There's this hospital position, hospitalist sort of director position. Let's start a hospitalist program in pediatrics. It's in Salt Lake City. Oh, we should go look, and they'll probably pay for my ticket, and it's December, so I think, this is a year later. I think I can arrange it so have the interview on the 22nd, so they'll pay for our flight. This is like totally fellow thinking. Pay for our flight, we'll stay with the in-laws, I'll buy a Southwest ticket from Boise to Salt Lake and go back and forth, and I'll just come and interview. So that's actually exactly what happened. And I remember my wife waking up saying, well, we're not moving to Salt Lake City. And I'm just like, Brett, we're not moving to Salt Lake City. I'm gonna work at Sick Kids in Toronto or Boston Children's in Harvard. That's it. I've seen the light. That is all I'm ever gonna do. Get on the plane, come here, call my wife at the end of the day, and I'm like, so, what do you think about Salt Lake City? And so this part's true. I'll say this. 5 times in the interview, I know you're not supposed to do this, so I won't reveal any names. People asked me if I had sort of a religious bent, and if so, what that might be. And I was like, I didn't think you're supposed to do that in an interview, but 5 times, Bretta. And then she's saying, well, you know why, right? And I'm a Hindu. Like, what do I know? And then she says, well, it's because it's the home of the LDS Church. And I said, oh, cool. What's that? Honey, when we were watching these commercials, and then there's this really family moment, and then you start to cry. And I'm like, yeah. She's like, they make those commercials. And I was like, I love them. Okay, so ended up moving here. Started off my clinical practice as a hospitalist. Rena, work with Rena. I have the pleasure. We have a fantastic group. At the time, there were only 2 of us, and we basically carried a pager 24/7. And Tiffany Glasgow and I. There was another one, Ben Meisel. He was the chief, and then eventually we got a 4th, Nicole. So we just carried a pager, and we said, hey, we want to admit all your patients. Send them to us. We're hospitalists. We'll just take care of them. Because the community was looking after the inpatients 95% of the time. We had like a 5% market share. Now it's flipped. We have 95% of the patients, and the community has 5%. So over 20 years, there's been this dramatic change. But after a couple of years, I was actually pretty clinical, like all 85% clinical. Apparently, that's not the way you're supposed to do it in academia, but I bargained for more clinical time rather than less, because I thought I just spent 2 years in a fellowship. Like, yeah, I'd done a lot of transport team and stuff and service. I loved it, but I really just wanted to see patients. But after 2 years of doing that, it made me realize, there's something in the system we've got to fix. So let's try to, I'm going to try to figure that out. Took this researcher route, which is not something I would recommend all the time, because you've really got to want it. And so I'm just going to write this here. And this researcher route taught me a lot. Taught me how to think about problems, how to figure out an approach, how to design potential solutions, but most importantly, how to test if it's going to work, and then write about it so we could prove if it worked or didn't work. That concept is crucial when we're going to solve the problems in healthcare today. And so I did that for a number of years. And then the last thing, as Todd said, worked in a network. I'm actually going to tell you that story. So the story is a little bit 10 years old. And I know I'm going to get to my slides. I know I'm talking a lot. But I'll get to the slides because I think it's important to understand where we're all coming from to figure out how we're going to get there together. The last thing is I took this job. And so and I actually think this really is a triangle. Now I'm an administrator, so I'm looking at research for the organization and thinking, how do we organize it and design it? And believe it or not, all 3 of these entities want the same thing. They really do. So I'm going to tell you the story of how did we get all 3 entities to work together, and then you guys can tell us if you think we've made a difference so far. So I'm just going to go through quickly the challenges facing the healthcare delivery system. I know you've heard a lot about it this week. And then what I'm calling care delivery science. So care delivery science, it made up term. In fact, I kind of made it up too, a little bit with some friends around the country. I think care delivery science is like health services research. Health services researcher that's applied health services research. So we're going to figure out in the system what works, but we're actually going to do it in the system. We're not going to do it in a room. We're not going to do it in one place. We're going to do it at the system level. And we're going to apply it. So it's got to be practical. People have to understand it. Frontline providers have to believe in what we're doing. So that's the application process. And the reason I call it care delivery science is, first of all, not all health services researchers do that. So we're already a niche group. Secondly, we're only caring about the science behind the care delivery system. Why is it we know something and we don't practice it the next day? Is it because we know we need one of our colleagues to send an email and say, the evidence kind of says this? And we're like, yeah, but this case doesn't do this. But there's a science behind it. It's not simple. It's not easy. It's still not completely well defined. But that's actually the research I ended up doing. I got this Career Development Award and spent a lot of years thinking about how we would do that. Brent was actually my mentor on that project, and then flipped over to Mike Dean, who's a division chief in critical care here. So I'm going to give you guys some national pediatric examples of these types of projects we've done. And then I'll talk at the end just briefly about how Intermountain is trying to do this as well. Can I just ask, are there any pediatric folks in the audience, just so I know? Okay. Okay, so you probably actually may know some of these studies. So I think these are the things that are coming out as I sort of see the challenges, it's aligning the leadership. How do we all decide what is it we're going to do? We need access and health insurance for our patients. We need to be able to, they need to be able to afford the care that they, to help them. There's a lot of this variation in clinical care without demonstrated better outcomes. So people are so firm. I do A, well, I do B. But we don't know which one's better. So we just need to know, because once we know, everybody will do it, right? Not always true, but if we don't know, then we're a little bit at fault. Then once we know, we got to translate that into routine practice. That's that care delivery science. That is super hard to do. Keep it going every day, every time. Data tracking mechanisms, that if you have on the outcomes and the costs, I think helps people translate. How many times did somebody come up and say, well, I followed this care process model? Well, do you ever get those results back? Do you ever just say, I'm sorry, I've got this device here that 10 years ago just kind of came out. This thing can do all kinds of things. If this is the technology that's out there, why is it in healthcare we can't say the last 5 patients, these are their outcomes, and that's what compared to the other 120,000 that your hospital has treated over years, adjusted for whatever. But we know the data's there. We just don't have it. But this mechanism, this loop, I think will change clinical practice much more than many things we've tried. And then this is our challenge, and especially here at Intermountain. We're about, depending on the exact numbers, we're about 40% at risk today. So we're not 0. Some places are still 0. I don't know if, does anybody know what percent where they're at, their payment is at risk? Anybody know? I just don't. I didn't know until I got here. So if not, you should find out, because I think it's really interesting to know how you're paid, because that's how you're incentivized and what people are focused on. And that could be one of these misaligned things right at the top. Some of the things we discovered in pediatrics was if we did this, then the hospital would make less. Well, here's the thing. Our CEO actually didn't care. They were like, is that the right thing to do? Yes. Then can you please do it? But people talk about these misaligned incentives. Turns out, I think we actually have a pretty special CEO who said that, and that won't always be the case. So you just want to know what you're getting into when you start. Okay, so after my stint of being a researcher on my own, by the way, this K Award, one of the loneliest things I'd ever done. I can't believe I kept trying to do it, because it took me 4 years and 5 tries. So I'm definitely a story of failure if you ever want to see one. So tried 5 times to get it, 2 mentors, 2 different agencies, finally got this grant. And then the second I got it, my wife's like, okay, you must be happy. I'm like, I'm bored. I'm in the room studying this one problem all the time. I need to work with other people. We need to do things. So the year I did get my K Award, I kind of did this as well at the same time. I had all this protected time. So as long as it was research and it was sort of couched towards what I was doing, I was told that was okay. So I ended up taking over to be the chair of this network, PRISE, Pediatric Research in Patient Settings. I don't know if anybody's heard of it. So it's a small group that started in 2002 by my colleague Chris Landergan that I did fellowship with. So he had his K Award. Everybody I know is light years ahead of me. So he got his K Award right after fellowship. I had to wait 8 years, 7 years. And so Chris got his K Award, formed this network, Hospitalists, totally eager, especially at the time, they're new, so they want to change the world. They're just young and not as experienced in the academic world. So formed that group. They did a lot of things in the first 7 years, but it was all voluntary. Nobody was paid. So, sort of survey-based research. How do you treat patients? How do you treat patients? Oh, look, you do a better job than you do. Sort of very convincing evidence. But it was actually really nice to build goodwill. 2008 rolls around, and we have this national meeting. So this is 10 years ago, okay? Not 20 when I started, 10 years ago. The national meeting, 22 leaders from hospital medicine fly into Chicago, sponsored by the Society of Hospital Medicine. Here's the charge. Make yourselves a specialty in 10 years. Okay? Rena, if I forget at the end, make sure I tell people where we are on that journey, okay? But at that time, make yourselves a specialty. By the way the adults are doing that specialty may not work. So, but in peds, you got to figure it out your way. And figure out in priority what you have to get right. So there were like 40 initiatives. By the way, this is published, so if you want to read about it, I'm not sure anybody does, but if you want to read about it, I'm happy to show it to you. There's like 40 initiatives, and we actually have a physician executive from Seattle, Sandy Meltzer, who helps us prioritize the group. So I'm thinking, we are not going to get anything done in a day and a half. But we actually got it done, identified the issues, prioritized it, voted. This won't be in the paper. The number one thing to fix if you're going to be a specialty, does anybody know? Fix the research. If you cannot define what it is you're doing as a field, you will never be a board certified specialty. That was the number one thing. And so I was asked to lead the group. Actually, what I was asked to do was sort of get a group together to think about how to redesign prize. So I was actually pretty naive. I'm like, yeah, sure. So call some friends. Those are the friends here on the right. So at the time, Karen Wilson, she is now the vice chair of research and the division chief in New York. Myself, Chris, who was the past chair of prize. Pat Conway, some of you may know, was the CMO of CMS, is now the CEO of Blue Cross Blue Shield in North Carolina. Ron Caron, who's at Children's Hospital of Philadelphia, Chief Quality Officer. Sanjay Mahant, who's a pediatric hospitalist in Toronto. Samir Shah, who's now the division chief of hospital medicine at Cincinnati Children's. Jay Berry, who's a hospitalist in Boston Children's. Theo Zotis, who's the division chief of IV at CHOP. Lisa McLeod, who is a surgical hospitalist director in Denver Children's. Chris Bonafide, who's a hospitalist at CHOP, and Pat Brady, who's a hospitalist at Cincinnati Children's. So not all these people were there at the time. There were 8 of us. And then Joel Teeter and Tamara Simon from Seattle Children's were there. So 6 of us on that list, and then those 2. So that made 8. All assistant professors. So in the academic rank, we sort of are helpful, but we're supposed to see a lot of patients before we can prove ourselves. And there was one person who had just become an associate professor, Ron. Because if you know Ron, he's just super smart and can actually do a lot of things. So that's the group. And this is that triangle I was talking about. I wrote it backwards on this thing. And then here's what we did. Who were our partners? Who were these hospitalists? We had over 100 sites say they were a hospitalist network. So we had to go back to them. Are you really? What does it mean? By the way, we have an awesome business model. We charge nothing. Okay? This is so academic, you're not even going to believe it. It's so awesome. Charge nothing and commit yourselves, though, to work. Okay? Just remember that. That's our story. So, and then each of these represents where an executive council member was. So, true story, we're all sitting, I really was naive. We're all sitting in PAS, this Pediatric Academic Society meeting. We're in a room. The APA, which actually helped Prize, gave it some resources. Halftime coordinator, project coordinator for like 5 years. That leadership is there. They're helping us turn over from the old Prize leadership to the new Prize leadership. And then we're all in the room, and they're like, hey, we need a chair. And they're like, okay, so whoever doesn't want to be a chair, step back. And I'm standing in the middle. And then I'm realizing, oh, crap, that's the way it was going to play. I honestly didn't know. They just said, Raj, why don't you start? You've been organizing the group, and let's just see what we can do. So that's how we started. Okay. So what did we do first? We have no money, so we need money. If we are going to fix the problems in healthcare, who should want to pay? Any ideas? Yeah, but who has money today? Yeah, insurance companies, yeah. Hospitals. Who runs a hospital? A CEO. So we went to the CEOs. And they gave us $1.4 million. In fact, we weren't going fast enough, so then they gave us another $250,000. That's like an R01. Just from a researcher point of view, I was blown away. I'm like, oh my gosh, I can't believe that these people want to pay. But here's what happened. Here's what we said. This should be very Intermountain-esque. because Brent James and Mike Dean, who's up at the U, they were on our advisory panel. Why? Because they would take my call. And so I would say, what should we do? We had the inaugural meeting 2008 here in Salt Lake, and Brent comes in and says, what do you guys want to do? And we said, we want to change the world. We want to study things that are going to change daily practice. And here's the thing, well, not all of us said this, I said this, we don't just care about publishing. Okay, if it ends up in the New England Journal, that's nice, but we really want to know how many patient lives we've made better. And so they're like, okay, as long as you stick to that, you will definitely publish in top-tier journals and your careers will go far, but don't forget why you're doing it first and foremost. Don't let anybody beat that out of you. So that's what we stuck together at that time, and we kept going. So we went to the CEOs, and we said, hey, you guys, we think we can help you. By the way, this is 2008, Affordable Care Act, rumblings are going on. Turns out Brent James is on the cover of the New York Times Magazine on the Sunday, November 8th. That, I do like an overnight shift on Tuesday night, get on a plane on Wednesday. So I've been up for like 36 hours because like attendings don't have rules. I'm sick. I never get sick. I'm sick as a dog. Fly to Atlanta, go out to dinner that night, fall asleep at 1 in the morning. I may have had 3 glasses of wine. Fall asleep. Ron is banging on my door at 11. He's like, Raj, wake up. So I wake up. He's like, you're talking in 30 minutes. Oh my gosh. He's like getting me stuff. Anyways, we rush down. I walk in. There's 44 CEOs sitting there. They are the leadership of the Children's Hospital Association, and I'm on. And so I have 30 minutes to sell them to give us the money. And at the end of the day, at the end of the time, they're sold. In fact, I'm in sell mode. I'm a little bit of a salesman, okay? I'm just going to put it out there. I have very little skill except to sell ideas. So I'm selling this, and then Ron steps up, and he's like, okay, Raj, you can sit down now. I'll answer your questions. Because they were asking really hard questions. I'm like, yeah, we can do that. Ron's like, no, we can't do that. So it was a good combo. So here's what we pitched to them. We pitched to them the Intermountain prioritization idea. Somebody asked us, how do you prioritize? So we said, hey, how do you guys prioritize? How about we use your data to help you prioritize? That was it. Concept number 1. So here's how we did it. I think I have to run it. I think I have to run it this way. So here's what we said. This is actually a report we gave to them. We're going to take your existing data. Turns out, like 15 years before, a health services researcher in San Diego, UC San Diego, Paul Curtin and Blair Sadler, CEO and health services researcher combo, had this idea to create this database called the Fizz database. Anybody heard of it? Pediatric Health Information Systems. Here was their idea. Just get the line item billed charges dumped into a central repository and use it for group purchasing. Okay, that's how CHA gets money. That's what one of the services they sell. But these two say, let's use it for research. So for 10 years, no one did anything with the database. Now, can you open up a pediatric article without seeing like 12 Fizz studies coming out? And I'm sorry, because I think I've contributed to some of them. But the reason I bring it up is we're like, guys, your data's sitting there. Why don't we just use your data and let's prioritize? In fact, let's do it, and this is my interpretation, the Intermountain way. I wouldn't say that there. I'm saying that now, 10 years later. So we're going to help you identify the pediatric conditions in your hospitals that, this should sound really familiar, cumulatively expensive, prevalent, and exhibit a high inter-hospital variation in resource utilization. Your hospital, so kids get strokes. Your hospital, when the kid gets a stroke, gets 1 MRI per episode. Your hospital, the kid gets 4 MRIs per hospital. 4 must be better than 1, right? Well, we don't know. In fact, it all depends on, do we know it's a stroke, and what was the treatment, and what's going on, and all those types of things. But people aren't even looking at it that way. So we're like, we'll just take the data and we'll feed it back to you. So this is what we actually did. Here's what we told them. All we want to do is have your clinical leadership align with your hospital leadership. Just have a prioritized plan. That's it. By the way, Todd, now in this role, I'm thinking, wow, that's hard at the top. You're dealing with a fire not a real fire, but like an emergency at work every 5 minutes as administrator sometimes. So to sit back and say, but that's actually what's going to work. So that's what we said. This is what we're going to do. We're going to help them prioritize. So we actually did that, and we got their data. So how did we do it? So they have this Fizz database. It was like 3.5 million records of kids, and it was all ICD-9 codes based. So you can tell how old my story is because it's actually ICD-9. Finally, America joins the rest of the world. We're all in ICD-10. So ICD-9. This is all we said. Here's the problem also. We're clinical researchers. I don't like codes. I think codes are really not helpful. I get these things that the coders say, what did you do? I'm like, this really is the best we've got to identify kids. Here's the thing though. All we're trying to do is get the clinical leadership to buy into these are conditions maybe that should be prioritized, and then go see if there's something that needs to be done with them. That's all this exercise was, okay? So we said, we'll take your codes and we'll put it through some kind of clinical translator that we created. It's actually like licensed by CHOP, I think. I am sure absolutely nobody has used it since then. But we went through this experience. We actually even called people, I don't know if you know, so there's like Lisa Iazzoni who helped create the groupers for chronic conditions back in the late 80s in Boston. So she trained me, and so we're like, hey, how did you do that? We called people, so this is kind of what we did. Ron and I came up with this idea. So we said, okay, here's how we're gonna do it. We're gonna take all the 3.5 million, figure out their primary diagnosis, and make it into a condition grouper. Here's the concept. If you're trying to find this condition, appendicitis, you should have a diagnosis code that says appendicitis. There's only one. And then, because it's a surgical condition, there's only 2 types of primary principal procedures that should be done. It's either an open or a closed appendectomy. That's it. That's what we did. For that condition, we also then said you have to throw out all those procedures that are not helpful. So no G-tubes, no ear tubes, no craniotomies, nothing there. And so we threw out all those cases. So we just did that for 504 conditions. Those 504 conditions account for, in a Pareto chart, 80% of what's done in children's hospitals at that time. Okay, it accounted for same-day surgery, as well as ER care and hospital care. So their book of business from a CEO point of view. So that's how we came up with the conditions. Here's number 2, what we had to wrestle with. How are we gonna say, we're trying to identify inter-hospital variation of stuff. So it's easy if you go condition by condition. So now I've got appendicitis. Now I'm gonna compare which ones use this device, which ones use this anesthetic, which ones keep this kid a day, which ones let them. Here's the problem. You'd have to do that 540 times. It would take years to do it. So we couldn't do it that way. We had to come up with a way to standardize. The way we thought was, if we're trying to identify variation in the stuff hospitals are doing, we need to come up with a common way of knowing what that stuff is. And because it's 2009 now, and everybody cares about the affordable value care, or we're all talking about it more, let's talk about costs. We don't actually know, none of these hospitals actually had what I consider, well, what I would say as a health services researcher, really good cost systems, except for Intermountain. So we took all 3.5 million and we said, let's come up with a costing mechanism. So here's how you did it, for example, the CBC. So we took the charge of a CBC and we figured out what the median charge was in that hospital for all those years, okay? Then we used just health services research methods, backed into what the cost was. It's a ratio. And you adjust it for if you're in the Northeast, things are more expensive than if you're in the Southwest, all that sort of stuff. So here's what happens when you do that. We thought we were so smart. We're like, oh, this is the way everybody does it. Here's the actual then cost of a CBC. In this hospital, it's $6. In this hospital, it's $66. That's it. Because charges are not real. They are the insurance company deal. They are they're all those things. They don't mean anything. But the cost, what is the cost of a CBC? Anybody know? Well, it all depends on the methods you use to calculate it, but it's probably not $6. It's probably not 66. And then looking at those engineering principles, and Intermountain has done this historically, it does matter if you're a high volume place or a low volume place, right? Because if you're high volume, you get really good at it. So you want a standardized way, because even if you get a CBC at Primary Children's, to me, I want to know, is that different than a CBC in Delta? But I want it standardized, because a CBC in my mind is just a CBC. I just want to know, are you ordering more? Because then if you're doing more, why for the same condition? That's all we're trying to get to. So the way we came up with this was we just came up with a standardized cost master. We just used the data. So what's this red line? It's the median. The median CBCs for 3.5 million kids in 44 children's hospitals. It's $32. That's not real. That's just the median. We did that for all 22,000 things that are done in children's hospitals. Well, the computer did that. And that's actually kind of cool, because now you have an MRI is 1,200 or an X-ray is this. Now here's the actual complexity. This is actually the chest X-ray, okay? This is the actual, what the spreadsheet says. This is why I think nobody uses this, because kind of, it's so detailed. Okay, this is actually true. Chest PA and lateral X-ray routine or unspecified. This is the code. There were 34 hospitals who used it. 5.4 million patient days used the code. And the cost master index, that red line, is $64.1328. Okay? Let me do this one. Chest AP. This is the one I want. Chest AP, portable, 16 hospitals, 4.5. Then you could do the same chest PA, right? So it depends where the plate is. I trained in Canada, so that's how we had plates. I don't know if it's still done that way. So only 5 hospitals use it, less, and it's $50. That's these 22,000 things. This is one. So you have to like standardize it for that. And then all you do is instead of you make up a column that says standardized cost and impute what was done. And then you roll it up, and then you've got data. So what's the data then we had? We had this data. So we actually had, and I'm just going to show you, this is actually Primary Children's report at the time. So we had, these are the conditions with the greatest savings in standardized costs. Why is it greatest savings? I'll talk to you. So the number one condition is surgical. It's hypertrophy of the tonsils and adenoids. The average length of stay at all these children's hospitals using methods to adjust for volume and case mix and payer type and those types of things is 1.07 days. At Primary Children's is 1.03. It's a difference of 0.04 days. So it's really nothing. All children's hospitals, 230,000 cases. That is the number one thing done in children's hospitals today, by the way, taking out your tonsils. Do you guys know what the number 2 thing is? Ear tubes. No wonder ENT surgeons have the best parking spots. The average at primaries was 4,800 cases for those 6 years. The means, remember the standardized cost master index, so this is not real, this is standardized. At all hospitals was 2,600. At primaries it was 1,700. So it's not the 0.04 days wasn't a difference of $900, there's something else. And then when you get to the percentage, by the way, just so you guys know, this is like 2% of all the cases when you take all the 500 conditions. It's like a less than 2% issue. But the O to E ratio, this is the observed to expected. So has you guys seen these charts of observed to expected? Observed is what your actual data shows. Expected is what the computer spits out in a regression model depending on what you control for. So we did a model for every condition in every children's hospital 500 times. And we handed them back their reports. That's what they paid for. We said, this is what you want. By the way, Primary Children's, you are 38% less resource utilization compared to your peers across the country. That's what we showed them, their conditions that were greatest. Then we said, we'll even make it easy for you, because you guys are used to what's in the black and what's in the red. This was sort of the idea we had. These are the conditions where you're spending less. Hypertrophy of the tonsils and adenoids. and then it's scoliosis, then it's otitis media unspecified, ear tubes, then it's mucopolysaccharidosis. Like, these are the conditions we came up with. And then these are the conditions where you're in the red. You're spending more. Number one for primary children's, bronchiolitis. Why? We had a care pathway, and the care pathway really designated everything you do, and we forgot to keep our eye on the ball, and we took away that physician choice, and so we just kept patients, and we were just sucking them out with their stuff all day, and they just stayed an extra day. We were the biggest length of stay at primary children's in the country at that year. Okay, we fixed that since then. And then we even showed them, where are you in relation to each other? So this is primary children's. So I presented this to our pediatric ENT docs, so Albert Park in the group. I had 5 out of the 6 ENT surgeons, so I thought they must be interested. Albert stands up and he's like, who are these 3? I want to call them. Well, here's the thing. Albert, great. I don't know if that's better. I'm just telling you you're using less resources. Don't you want to know your outcomes? So then the other thing we did for the CEO project was we actually told them what we thought was going to be better. So we said, let's measure the variation and let's track your outcomes, and we'll hand you those reports. So we did it for 4 conditions. So the first condition, this was actually great. There was a clinical guideline that came out. So we called Reginald Baugh. He was actually really polite. He's like, oh, I love this idea, but I really have no time for this. So he actually gave us somebody else on the project who ended up working with us on this. This was a great project. We had ENT surgeons and health services researchers, and this is what we came up with. The guidelines said, for every kid who routinely gets their tonsils out, same-day surgery, right? So no complexity, no, they can't have asthma, they can't have any other problems, don't do any other procedures. We basically used the data to clean it the same way the guidelines said. By the way, we started with 300,000 kids, and we ended up with 150,000 in the database to match the guidelines. I've never done a study where I've thrown out 150,000 kids. But, we were almost adult-esque in our numbers at the end, because in kids you just don't have the same numbers. So, but this is what we gave these report cards to the hospitals. We said the data says everybody gets a dose of Dex, because the randomized controlled trial says if you give somebody dexamethasone after their tonsils, they feel less nauseous, they vomit less, and they won't come back to the ER and need fluids. Awesome. Also, routine antibiotics you don't ever give. All you give them is C. diff, and it doesn't actually prevent an infection. Okay, so we looked at those 2 measures, and we said, Hospital 2024, you are doing the right thing by giving dexamethasone 92% of your routine cases. And you're giving antibiotics 5% of your routine cases. Woo, you guys are the best. That's your quality score, so process measure. Just remember 2024. Then we said, let's give you your outcome. What's your 30-day return visit? This was like 2010 now, this is 2011, 2012, so lots of readmission stuff in the literature. The HARP program comes out. And so we tell them, this is sort of where each hospital is on their readmission rate. And Hospital 2024, your readmissions are really low. Okay, so good quality and low readmissions. Let's keep that story going. What do ENT surgeons care about? One thing. Which of my patients bleed? It is a universal, they want to know this. Not all bleeding needs to go to the OR, but it's just an outcome measure. International societies call for surgeons. Are there ENT surgeons here? Okay. So I'm told international societies called for ENT surgeons to say, know your bleed rate. This is where we got some traction with our ENT surgeons too. Looking at this 150,000 in the bleed rate, the best data out of Europe with RCTs and follow-up, few hundred patients, say the actual bleed rate is 3.3%. Looking at 150,000 kids who have this outcome, this bleed rate is 3%. This is when the surgeons got really excited. They're like, whoa, you can use big data to actually, and the numbers are an order of magnitude so much bigger than anything we've been doing. Okay, maybe we'll believe this now. Now, Hospital 2024, where are you? Oh man, your bleed rate is a little higher. Shoot. What about your costs? Your standardized costs, right? Because we made those. So This was cool. We actually had the ENT surgeons go through all the billing codes and group them into just stuff that matters to them and is not beyond their control, okay? So it's what technique are they using, how long the kid stays in the OR in recovery, and what anesthetics are done. That's basically what they cared about. And so they took those codes and rank ordered them. That's actually the breakdown of each of the standardized costs for them. And this is hospital 2024? 2024. Wow, you've got a lot of brown, and it's a lot of this anesthetic. You're using a ton of it. That's the cost. I don't know if that's good, but I would think somebody now can, this is what we handed them. Somebody now can go back and say, what are we doing in tonsils? Let's figure this out. What are we doing, and is this okay? Because this hospital isn't doing a lot of that, and they're kind of half of the cost. And by the way, we've got their outcomes. So that was what that's what we ended up giving the CEOs. And we did 4 conditions for this. This is when they said we weren't going fast enough, so they give us the other 250. They're like, you did 2 conditions. We just gave you all this money. We want more. And I was like, this is when I started getting the inkling. I'm much more savvy, Todd, now, that CEOs want results quickly. And so this is when I was like, oh, we got to go faster. Okay. So this was what we found. Now, during that time, I was also working with other people. So there's an ENT surgeon, Jeremy Meyer, works at Primary Children's. Jeremy is like, Raj, I care about value care. And I'm like, okay. And he's like, will you mentor me? And I'm like, really? I'm like a pediatric hospitalist. What do I know about your stuff? And he's like, no, let's just work together. So I'm like, okay, fine, let's work together. Jeremy has 8 publications based on Intermountain data on tonsils alone. He has done unbelievable work. Here's what he's done. He's looked at our data and said, Raj, these are the 14 surgeons that are also exact same methods. I actually hooked him up with Sanjay Mahant, who did this work at Prize. Those guys are just, it's great. I just introduce them, they do all the work, and then they ask if I would like to help at various points. It's so nice. And so these guys do all the work, and Jeremy's like, Raj, this surgeon, this is how the PACU is, the OR supplies. Here's the thing about the Fizz database. It's a good high level, doesn't actually give you some detail that you need to make decisions. I want to know what the technique is. Turns out there are 5 that are routinely done, but Intermountain data can tell you what the 5 are. Here's that same graph, but broken up on electrocautery, 6,600 cases, coblation, 8,500 cases, microdebeater, 27, harmonic scalpel, 783, cold steel, 431. You just rip it out. Okay, so here is harmonic scalpel, 346. That's Intermountain costs. That's not standardized. That's our time-based, activity-based cost counting system. Look at electrocautery, $46. Okay, now we're getting somewhere. Why do people use the harmonic scalpel over electrocautery? Jeremy has done comparative effectiveness research studies using this data, and he's gotten the outcomes with the same complications that we looked at, no lower rates of bleeds, no lower rates of readmission. Why are people using it? So then he took it to the 75 practicing ENT surgeons at Intermountain. Many of them are not employed. They're affiliated. And he gave them their individual report cards. Now we're getting somewhere. Gives them the report cards, and what do they say? What's the first thing they say? My patients are sicker. Okay, so then he does all that. Then what's the next thing they say? Well, the kid returns to work easier. The harmonic scalpel, that's what the rep told me. I'm sorry, I know this is being recorded. I'm sure that's not what the rep says. But the harmonic scalpel is, only used by 2 ENT surgeons in the system. Okay? So somebody says, my patients return to work faster. So because we're Intermountain, Mark Ott, who's leading our surgical services, says, BS, gets 2 nurses to call 2,000 families in the next 6 months in a stratified randomized sample. Gives them the health-related quality of life, asks them all the right questions. Results? No difference. Okay, so why are we doing the harmonic scalpel? Okay, So that's what got our network started. Then the next thing we said, you know what, this Fizz data, it's not that helpful. You need results. I'm sorry, I know. As a clinician, this is true, I remember ordering a lab test and the white count comes back on the kid and it's like 95,000. By the way, that's not normal. And I'm like, what? No, come on, it's a mistake, right? What's the first thing I do? Repeat it. Okay, because the error rate's really low. What does it come back? 96,000. Oh, and they're blasts. That patient of mine has leukemia. Oh, I need data that's verifiable and trusted. By the way, that's me here, and guess what? That is me here. If I don't have that, I'm still making decisions. I'm back to, presenting data and making decisions. I need that. So that's why we all need the best data. So that was this project. I've got one slide on it. This is a $9 million, oh, by the way, this is like when, the funny thing is when we got our money from the CEOs, so we pitched that. Ron wrote a grant and to AHRQ to get money for this project. This is the concept. We need results if we're going to do comparative effectiveness research. They paid $9 million for that. We said we would, by the way, I know the iCentra is hard, right? Taking all the, here at Intermountain. This is what we did, kind of like a light version. Take all these children's hospitals and put them into one database and match all the labs so you could pull it out and do comparative effectiveness research studies. And then that's what we did. We mapped 140 million labs from these 6 children's hospitals into one source called Fizz+. 4 million micro records and 6 million radiology reports, not the actual images. Lots of people kept telling us about machine learning is going to solve the world, all this stuff, and we're like, we talked to the experts, we're like, no, we don't buy it. I mean, I know people use it. I just haven't, here's the thing. I need something I can act on the next day. I don't need it in 2 years. So it's still science. It's an experiment. So if I'm going to do a study, we did this study on, so this was actually my K award as well, but I handed it over to somebody. Brian Stone actually did the study. Children with neurological impairment, so kids have a variety of reasons, like they have a stroke, or they didn't have enough oxygen when they were born, or they have a brain tumor, they can't eat properly, and so they go, when they swallow, it goes down the wrong way in their lungs, causes aspiration pneumonia, so we feed them through a stomach tube. It's hard. And these families need answers. And what are the 2 things we do? We either feed them through a stomach, or we push that tube down through a GJ tube, really low. They have to be hooked up all the time. We just do dribble little amounts in, so they're not aspirating. Or we do this surgical procedure called the fundoplication, where we wrap the stomach really tight and it can't come up. Brian does a study, largest study ever published, comparative effectiveness research on A versus B. No difference. Okay? So that's why we created this database, so people would do that. And this is the sample of stuff we have in that database. So we thought, okay, what's step 2? Get the verifiable data. What's step 3? Let's answer questions that the clinician will need the next day so they can flip their practice. So here's what we do. So we say, what are those? So here's the problem. We have these conditions in pediatrics when kids get these infections. At the end, when they're sick, they get hospitalized, sometimes they need surgery. They might have a bone infection like osteomyelitis. And then at the end, we say, we know you need 4 to 6 weeks of antibiotics. Best evidence out there. Okay, yes, there are a couple of studies that say maybe you need less, but just bear with me. We think you need 4 to 6 weeks of antibiotics. Your 2 options are, we'll put this peripherally inserted central catheter, put it all the way there, sit right above your child's heart, and then we don't even send a nurse out to teach you how to do it. We watch you do it once, and then you go home, parents, caregivers, and you guys do it for 4 to 6 weeks. Option 1, because we don't want the infection to come back and have complications. It's a kid. Like if there's malunion or a problem, they might never walk normally again. That's huge. Okay, what's option 2? Take, not a pill because they're young, take an oral manifestation of the drug, just like take the syrup 3 times a day. That's it. Okay. Are there any parents in here? Okay. Who wants the oral drug? If it's better. If it's not, you're going to struggle. You're going to go through the 4 to 6 weeks. So, largest comparative effectiveness study done. This is also Ron got this money. He's like a really good grant writer. But basically, we say we have 45 friends in this prize network. We're going to call them. We're going to have them, we're going to give them their data, create this REDCap database. We're going to use the Fizz data to tell you, these are your patients, Peter. You're at this hospital. These are your patients. Will you just review the chart to see a couple things? Was it a PICC line? And verify just a few facts. Everything else will pull from the database. Would you agree to do this? By the way, we're going to pay you $7 a chart. And we need you to do it in a month. Okay, this study got IRB approval from 45. We used like not the single IRB, but a central IRB, but many didn't like that. Study gets funded. We train the network to do this. We get IRB approval and contracts in 2 months for all 45 hospitals. These are clinicians, by the way. These are not people who do research all the time. They just love the question. They're like, we do this. You're going to help us answer? Cool. Okay, Chris Miller is the one who did that for us because I ended up going on a sabbatical to Australia during this project. So engage the workforce, ask a really good question, have them review the charts. By the way, how long do we give them to review the charts? 2 months. Why? Because PCORI is breathing down our neck. Oh my gosh, that agency is so interesting. They're like, we give you the money, it's a contract, you've got milestones, you got to go really fast. We were the first group to get the comparative effectiveness research study out of PCORI. Their methods, and they're only a year away, I think, from being dissolved, but we got some money to be able to answer some questions. And then, so, you know, no one's reviewing the charts. Everything is red. And so we're like, what should we do? And we're like, oh, let's use these QI principles. Let's shame them. So 45 people get on a weekly call, and we show them the data, and we say, Peter, okay, I'm just kidding. Whoever, why are you red? No, we don't even say anything. People are like, all of a sudden you just see the blue start to come up. It's pretty awesome. We didn't, guys, we're one team. We're a hospitalist national group. We're just trying to answer the question. We just have time limits because you don't need to worry about why or the grant funding will run out or whatever, but people just came together and asked the question. I was super impressed. This is an amazing research project, and just like the administrative component underneath it just went pretty smoothly. Oh, turns out, anybody know the answer to the pivot study? It's published in Peds JAMA. No difference in treatment failure. 1,000 kids in each arm. Now, it's not a randomized controlled trial. Why? Because we did this back of the envelope calculation, $25 million to run a randomized controlled trial. Why is it $25 million? You need 5 years of data, you need 45 sites, you need to prospectively collect all the data, and it's going to run that long. Okay, I've got, I think, some of the best grant writers in the country working on this. I don't think we can get $25 million to answer this question. Okay, now I know we are never going to answer that question in RCT. What's our next best option? This. Is this enough to change practice? Because if it isn't, then nothing is enough to change practice. So we have to go with the best science we have. But then here's the beautiful thing, right? If you use QI principles and you really want to do this, run a collaborative afterwards. Capture all the data and watch it. Maybe some new bug is going to come out. Maybe something new is going to come out. That's also on us. We have that ability to do that. Again, I have this awesome device that can solve many problems here, or this one. Well, that's newer. But why can't we do that in healthcare? That's where we need to get to. And we know we can do it, and there are big disruptors coming into our field to try to help us. I'm not sure we're partnering at this level, but this is the meaningful work I think that's really going to help us get there. Okay, so then those are the studies we've done. I'm going to end on one last study. So anybody heard of iPass? Okay, a couple people. So our goal was to come up with studies, implementation science, care delivery science, things that can be practiced routinely that we can test in the real world. So here was the idea. And so I'm just going to tell you, first I'm going to start with what we, by the way, it works, okay? I just gave away the results. Turns out if you use this method of handoff at the end of a shift between interns, you will save lives. Okay, awesome. So that's the punchline. But let's go back for a second. We didn't know that in 2008. In 2008, Chris, that colleague of mine, he wrote this grant and got it funded. Also an amazing grant writer. Patient safety, right? We know where the air is human. That Intermountain has a byline on, because Brent James is sitting there writing it with the Institute of Medicine, that we know we've got 100,000, whatever, 50,000 to people quibbling about numbers. This is what people do. Something comes out and everybody argues. It's like, well, it's a problem. Yes, we don't quite know exactly, and there are different methods, but there's a problem. The methods matter, though, because if you want to show you're making a difference, you want to show you're doing it over time. Chris published this study in the New England looking at these hospitals in North Carolina saying 5 years later, nothing got better. Turns out that's actually true. Another IOM report came out. Brent actually wrote about it. Nothing got better. Great. Okay, so what's the problem we were trying to solve? Duty hours. Do you guys remember 2008? Before 2008, we could just make residents work forever. They just had to come to work, and they just had to stay there. So this is actually true when I was a resident. So when I was a resident, I would go to work at like 7 or 8 in the morning. I'd go at the last possible second because I'm just that type of person. So I would show up on my ward rotation, and I'd start at 7 or 8, can't remember which one, and I'd stay all day. Then I'd be on call at 5, and I'd stay all night admitting. Then I'd stay all the next day till like 5, 6, 7 at night, okay? Here's the problem. Sometimes I'd stay later. Peter, I see you're shaking your head. Sometimes you stay later because the cool stuff happens the day after. And the MRI result just came at 5 p.m. and I'm like, oh my gosh, that kid has CNS vasculitis. I've got to call rheumatology. They might want to start steroids. Now I'm on a high because I've been up for 36 hours and I love medicine and I want to figure this out. I'm in it. This is my patient. I've connected the family. I talked to the mom. They were crying all night. We don't know why the kid's in a coma. This is actually one of my cases that happened. So I stayed, right? Got home at like 9 at night. Turns out, totally not safe. We know that. We didn't admit it, but in 2008, regulations forced us to change. Okay, so regulations forced us to change, and in 2011, they change again. Here's what happens. We hired more residents. Nope. We hired more doctors. Nope. What did we do? Nothing. Because no one's going to pay for it. You just have to figure it out. But we let the residents have more breaks. Okay? And honestly, probably it was only going to happen if a regulation came out and said it. I would have liked it to happen a different way, but it didn't happen that way. So we let them sleep. We let them have breaks. There's more breaks in a handoff. So in that 36 hours, I didn't have to hand off to anybody. I knew the case. My senior knew the case. We all just knew the case. Now, in a 24-hour period, you can have 5 medical teams look after that same patient. By the way, patients are sicker. They stay less in the hospital. We do more. Okay, so we clearly have a standardized, structured handoff, because that's what you would expect from us. Anybody want to volunteer? We have a structured handoff in medicine. Guys, this is our business. Airline pilots, do they have a structured handoff? Anybody been on the tarmac? I'm sorry, your flight is delayed. Somebody has not gotten enough sleep. You've got to wait for this other flight to come in so the other crew can transfer over. Have you ever heard that in medicine? You would want to. I would think if you knew it. Okay, so that's the problem we have. We don't have a structured handoff. Not only that, the Joint Commission says 2/3 of sentinel events, sort of the biggest problems that we have to capture using that method, caused by communication failures. No, I think, huge surprise. Okay, so here's what happens. It's 2008. Chris and a colleague, Amy, she is a fellow. Remember that. This is her fellowship project, iPass. Amy Starmer and Ted Sektish, who's a residency director, the three of them are like, we're going to try this at 2 wards at Boston. We're going to come up with a communication and handoff skills training. We're going to come up with a mnemonic. We're going to redesign the verbal handoff process. And then we're going to call it the resident handoff bundle. Oh, and then they tested it 1 ward without a computer, 1 with a computer. You can tell it's 2008 because not everybody, Meaningful Act, high tech, not everybody is using computers on the wards. Okay, so here's what they find. It's actually published in JAMA. It's like 2 wards before and after. But it's pretty shocking. Turns out the medical errors before are 33.8 and after are 18.3. And the preventable adverse events drop by half. That's pretty remarkable data. And I think that's, well, JAMA probably took it because it was from Boston, but also because it was remarkable and no one had shown this. So what do we say? Remember, we're prize. We just got a bunch of money from the CEOs. We're sitting pretty. We're like, we're going to do meaningful studies. This was the 3rd study we launched that year. We just did them parallel. That's why I was never around the hospital, because I was either seeing patients or doing this. Okay, I have never done a study where we published 22 papers before the main results of the study. Why? We had educators. Anybody know an educator? They are the most passionate people who want to figure out how we train the next generation. You put them all in a room with clinicians, and one of them actually had a background in science, Dan West, UCSF program director. He had actually done some stuff on factor analysis and all these different qualitative approaches. So it's great to have even one researcher in the group, because here's what happens when you have one researcher in that group. You have 22 papers before you know the main results. Dan developed all these structured ways. So we're going to run a study. We're going to run a study, and let's just publish everything we do along the way. This is the way it should happen, because then you really start to add to the literature and tell people what happened. So what did we say? We're going to take that 2 hospital floor Boston study, and we're going to run it in 9 children's hospitals. And we're going to do it. We're going to try this implementing the handoff bundle. And Prize is going to help sponsor it. And fortunately, we got some money from the, what was it called? The stimulus bill. The $700 billion that was poured in to help jumpstart the economy. 1.1 billion of that was for comparative effectiveness research. That's what funded a lot of our work as well. Okay, so here was the idea. We have these hospitals. These are the hospitals up here. We're going to use a very systematic data error collection system. You can only do this in research. You basically have this daily rounds with the nurses and house staff, surveys, formal error reporting. Oh, and we want a letter from every CEO. Why? Because this is our first rodeo. We want them to commit resources, because this is only a $3 million grant. You cut it 10 ways, plus, of course, some of the investigators in the Data Coordinating Center need it. Nobody got paid for anything, virtually. It's not $7 a chart, but it's not much better. But people want to do meaningful work. So if you're going to do something, it's not, I don't actually think it's money that drives people to do it. It's that, are you going to do something that's going to make a difference to what I do every day? And that's what I've been trying to hit through in the theme. So here's what we do. We just update what they tried. That's a pilot. That's what a network is for. Try it somewhere, and then bring it to the mothership, and then let's run it everywhere. That's the beauty of this. So my gosh, there are adult learning principles and theory. I've learned more. I think I'm actually more published in educational research than some other areas, just because these people, there's all these things that should be done this a particular way, so we do it that way. Simplify the mnemonic. Turns out, Boston, they're not using the original mnemonic. Yeah, it was published in JAMA, but there's no sustainability. It had 9 things, too hard. So we come up with 5. We Redesign the verbal process. Turns out when we get in a room, nobody should have a pager. Should be in your own room. Should be quiet, you should be uninterrupted. We're handing off the sickest patients in the hospital, and you're at the earliest stage of your training. Oh, and we want your pager to go off every 5 minutes. Nope, not a good idea. Okay, and then we do a lot of quality improvement, rapid cycle iterations to get people engaged and involved and keep going. And that's what we call the bundle. So this is what it is, illness severity. So, I've got 12 patients on the service I'm handing off to you, and 2 of them are watchers. Can I start with the watchers? They're pretty sick. Here's what's going on. I give you a summary statement, the events leading up to the hospital, what their course is, what's the assessment, and what's the plan for the next 12 hours. That's your action list. I wrote it out for you. Can you do this? Can you own it? Will you check those labs at 2 in the morning? And then if the sodium is below 112, will you give them 3% sodium? Do we do that still? Okay, maybe not on the floor. Situational awareness and contingency planning. You have to know what's going on. And then synthesis by receiver. This is the hardest cultural part. Dylan, you have to know that if the sodium's low, what the underlying condition is and what the fluid status is and what's going on. And here's the thing, if it's a sodium problem, so you probably know this or you guys know this, I don't practice all that often and I forget things. And I'm like, is it this or is it that? I just forgot. And I wasn't on rounds. And the endocrinologist didn't come down and write it on a board. So I totally don't remember. So when Rena's signing this out to me, I have to say, Rena, I'm sorry, can you just walk me through the physiology about this? Because guess what? Sodium problems in hospital medicine, it's a 2% issue. It only comes up 2% of the time. I can't remember it. So you have to say, no, Raj, that's what cerebral salt wasting was, if that's a thing, or that's, this is this and this is that. You gotta catch me up. And here's the thing, I gotta admit to you, I'm not super smart. I actually do not remember a lot of things. So I need your help. Very hard to do culturally, right? But that's intern to intern. They're all brand new. That's what we teach them to. Okay, so came up with this bundle. There's a workshop, and this Team Steps training, AHRQ loves us. They came up with this training. I don't know if anybody's heard of Team Steps, adopted from the DoD. I think we have a really awesome story for them to say, well, if you applied Team Steps like they did in the iPass, it actually works. And so we took their training, simulation. This is, guys, we have this in the delivery system. This is what simulation's about. Put people through stuff and then see if the stuff works and helps patients get better. Just measure it. Just design it that way. If you just do it and you don't check it, you don't know if you're making a difference. Kate gave this printed handoff document. This was good for us. Adjusted the computer. So back when we had Patient Chameleon, Patient Tracker, prior to iCentra, we used to we totally made it adapt for iPass, right? Faculty development. Oh my gosh. Turns out none of us had ever trained how to do structured handoff. So we created a whole new medical education module on how you train people to do this. Guys, this has been done ever since medicine has been around. Like even Osler and Rounds. You had to hand off. We've never written down how to hand off. That's kind of scary. This is a huge piece, having somebody watch you. Turns out it's a little intimidating. But during this, I remember during the study, I'd go up and just walk in a room and the residents like, well, first they'd say, who are you? Because they don't know me. Second, they'd say, what are you doing? And I'm like, I'm just watching you. And I'm taking out this piece of paper and checking boxes. Why are you doing that? Well, I'm judging you. Oh my gosh, and the way you interact with people really matters. So hey, we're just doing a study. You guys do what you do. We're trying to figure out how to help people get better. So if you don't mind just doing it the way you normally do it, I'll give you some feedback. You decide to do with it what you want. We think, but here's the scientist in me. I don't actually know if anything is going to work, and I won't know for 4 years, but I think it's going to help you. I think it's going to help your patient, so can we go through this, right? 'Cause some people are touchy. You got to really get them on your side. You can't just come in and check boxes and say, you failed. Although, honestly, sometimes attendings act that way. So that's not going to work. You're not going to change anybody there. And then this campaign, and then we had the mnemonic. So that's what we did. This is sort of the actual details behind it. We came up with this faculty champions guide. This was cool. A few of us at our, Tiffany and Brian and others were faculty champions, and so they had to read this module. We had to train them on how to do it. These are some pictures. There's actually like signs all over the computer so that people remember. We actually, Cincinnati did have fortune cookies. So there were, if you broke it open, it'd say like, did you start with Watcher? Like they were actually fortune cookies with iPass. Food helps. This was the study design. This is, okay, guys, this is not a randomized control trial. We didn't have equipoise. We did not believe by putting this together that we were going to hurt people. We thought it was going to work. So if you can't randomize, what can you do? Well, we can do a staged intervention in waves, do a few hospitals on the West Coast, then a few in the middle, and then a few on the East Coast over time, collect the same baseline and post period over and over again, and then because it's residents, they change every year, so you got to have the same baseline post collection has to be at the same time of year, and so that's how we do it. And that's actually how we've done all of our series of iPass studies. We're actually on study 4 now. This is the original. And this is what we found. Before the intervention in yellow, people talked about how sick their patients were 5% of the time. Look at the blue. Do you see anything at 100%? No. This is real life interventions. These are 10,000 patients in this study. This one, we only looked at 207 random samples, and they accounted for 2,200 of the handoffs. Because there's a ton, right? But because it's science, you can do random sampling, and you can do all these things that are pretty good, so it's not biased. This is probably the truth. Synthesis by receiver, the read back, 45%. So only half the time would I tell Rena I didn't know what was going on. The other half I was too intimidated because she's intimidating. Okay, this was the written handoff. Okay, a little better, right? Pre-populated with the computer. We do fill in some stuff, so that's pretty good. And here's the punchline. Here are the results. I already told you it worked, right? Okay, so it worked. So what worked? The overall medical errors per 100 patients, so for every 100 children, every 100 patients, kids admitted to these children's hospitals, 24 of them, so a quarter of them have a medical error. And we dropped that, I should say, our intervention was associated with a drop of that. I don't know if we did that. We didn't do a randomized controlled trial. But it's associated, okay? That's the best we've got, 18.8. What about the preventable adverse events? This is what got a lot of attention. 4.7 out of every 100 kids has harm that could be prevented. We dropped that to 3.3. It's not 0, but it's still like a 23% drop. For a routine thing you would expect your doctors to be doing anyways. And then your near misses, no difference, or a little bit of a drop. And then the non-preventable adverse events, no difference, because people don't think you can really change these non-preventable things. They're non-preventable. I didn't know. I didn't know you were you didn't know you were allergic to this drug. I gave you the drug. You had an allergic reaction. Nobody could have known that. Okay. Well, if you're ever going to do a study and try to convince people, you got to have all the balancing measures, meaning what are all the things you're taking away from them, and you got to measure that. This is really cool. We had a time motion study. So we followed a sample of the 880 residents in the study, and we watched what they did during their 12-hour shift every 6 seconds and recorded what they did. I remember being the attending on service, and so there's something pretty humbling about thinking about these studies and doing it and then actually being involved. So I'm sitting there and we're rounding and I'm like, who are you? And there's somebody with an iPad and they're like hitting this button. I'm like, what are you doing? What are you talking about? And all it says is attending rambling. And they just kept hitting that every 6 seconds. And I was like, oh yeah, I'm like the first person to go through iPass. It was actually super cool. Here's the thing. Best data, patient-family contact, they are doing it 12% of the time. Okay, well, it wasn't less, right? Didn't get worse. What about creating the document? No, it takes about 1.5% of the time. What about other computer time? Well, they're doing that 16%. Some of the adult literature is 25% for computer stuff, but on peds it was 16%. We just have less to write because there's, okay, anyways. Exactly. And here's the kicker. How long does it take to hand off, right? Oh my gosh, the screams from the senior residents for that whole year, that's all I know how to do this, is gonna take me so long, all this sort of stuff. People are so convinced. And then you measure it. Turns out, actually doesn't take you any more time. Doesn't take you any more time, safer for your patients, something you should be doing anyways. Anybody want to opt for another option? If your child gets admitted, do you want them not to get this? Okay, so here's the thing. When you do eventually publish it, you got to give credit to everybody. It's not the people who got the funding. It's not the people who just conceived the study. It's the teams of people that it takes to do this work. That is huge. So we did have I think it's 34 named authors, and then we had the iPass study group. What's that asterisk? It basically, it doesn't go through here. It actually lists all the study members. I'll show you that at the end. So when you find something, you want to share it, right? So how did we decide to share it? We made a website. This is what you do in academia, right? You share it. You can go to this website. You still can. You can download everything you want, all the materials, all the papers. So have people been doing it? Well, this is sort of the people who have downloaded the material. Just a few thousand, just around the world. This was my 2013 sabbatical. We saw that number go up after I went around. Actually, Chris did a sabbatical too there. So, but anyways, Ron went to London, but I don't think, yeah. So, but anyways, you go around, you give grand rounds, you talk, you publish. People want to know these things. So, does that make a difference? Okay, so then who's downloading it? Physicians, 75% of the time. Med students, nurses. What are the disciplines? It's not just pediatrics. It's only less than a third of who's downloading it. There's all these other disciplines that are downloading it. Turns out we've done a lot of other studies. We've done them with nurses, we've done them with surgeons, and then people have taken our materials and tried it in their own area, right? Can this work? What does it look? Is it as rigorous as the original? No. I mean, it's really hard to pull off a study like that. And if we always have to hold ourselves to that, it's going to be hard to change. So, but people have done all kinds of things. What have we done? Well, you're a network, you got to get more money. And you just got to keep going. All of these grants are 3 years. They make for a busy 3 years. So you got to start again. So we said, well, let's take this and spread this to the adult hospitals, right? Because this is peds. How much attention do we get? I mean, it's honestly, if you can do it in internal medicine, that's where it can stick. And so we did that in internal medicine. And so we're trying it. And actually, it turns out, large study, the results will be released soon. More processes, they follow more processes, and the reported errors are less. This study is not as comprehensive error collection as the original study, because we had 32 sites, not 9, and we had less money. We had $1 million less, so it gets spread less. This is a massive QI project that we did with the Society of Hospital Medicine. These are sort of some of the other studies we keep going. I mean, this model, I gotta be honest, I don't think it should be their jobs to just get money to solve things. I don't. I think if we're solving things that help this group and this group, we've got to figure out a different funding stream. I don't think the feds can pay for everything. I think it should be a public-private partnership. That's what we did in PRIZE. We got the CEOs to pay, then we got a 13-to-1 return on their investment. We got $12 more million, you gave us $1. Okay, that's a reasonable investment. Did we help? Did we do things that mattered? So I just want to talk about this study. This was the one we're doing now, family-centered iPass, where we're like, let's change the way we round. Let's engage the patients. Hey, Ann, how are you? That's our director of patient engagement. That's why I said that. So honestly, I really think families want to participate. So let's get them to participate. So we designed this intervention. We took iPass and we said, let's give it to the hands of the families. And let's get the nurses involved. And let's round as a team. And so that's what we did there. And why is that hard to do family center rounds? Well, does anybody know when I start rounds? No, because I can come when I want. I might be late. I'll show up an hour later while everybody's waiting around for me. How do we speak to the families? Your child has a fever. No, your child's febrile. Blah, 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 blah. What? What does that mean? We don't explain all the data. And then, any questions? Nope. OK, I got to go. I've got my hand on the door, actually, as I'm asking that question. Do you have any questions? Because I'm going to run. So this is actually how we thought about just doing family center rounds and engaging the families. Put them in the middle. Let's figure out family-centered rounds. Let the family speak first. What are your concerns today? You would think this is routinely practiced. It is not routinely practiced, even in children's hospitals. We're pretty good, but we still have room to improve. So use plain language, bi-directional communication, use the iPass format. This is how we adapted the original iPass format. Is your child better, worse, or about the same since we came in yesterday? That's it. That one global thing. It is amazing what they say and how much information that one question. And even if everybody on the team doesn't pick it up, I can see it on rounds. I'm like, oh my gosh, they are screaming to you, this kid's not better. We got to listen. Because you know what? The family actually is always right. They know their kid. They've had their kid their whole life. I'm just there for like 5 minutes. Really? They're not better? OK, what's going on? We got to figure that out. What's a situational awareness? What are the things a family and patient should look for? And then here's the thing we did. Let's get the families to read back. Oh my gosh, we got to 45% in the original study. So now I've explained all this information. Can you just tell me what I said? Talk about intimidating. We wrestled with this for a long time. We actually have a patient advisory group that we went to and said, what do you think? And they gave us all kinds of tips to try it. The one I like anecdotally is I've seen the seniors do this. Hey, so we've just given you a lot of information. As a test for how our team is communicating with you, can you just, in your own words, tell me what you think is going to happen today? And by the way, I also wrote it on the board, because I did, because when I leave, you know, oh, and your nurse is right there. And so you can ask your nurse if you're not sure, because guess what? I'm here for 5 minutes every day. They're here for 23 hours and 55 minutes more than I am. That works so well. Now, does everybody do that? It's hard. And actually, it's really intimidating to talk to families using living room language. I feel like I'm not practicing medicine sometimes, because I'm just like, well, you know, there's all kinds of reasons. It could be this or that, and we're going to try this. And then I'm gauging, do they want more? Oh, you do want more. OK, you know what? Can we just break for 5 minutes? Can I actually go into some of the reasons and start explaining it, because they really are there? You got to really understand what families want. Structured communication. We now do these mid-shift huddles, and then we do overnight huddles. We actually, who's the sickest patient? It's actually kind of cool, where everybody's like, it's really interesting, my first overnight huddle, and I don't actually do overnight call anymore in the last couple of years, but I did when I started this job. And so I'm standing there, and it's like, I think it's 10 o'clock at night, and people are calling me, Raj, where are you? I'm like, what are you talking about? It's 10 o'clock at night. We're doing the overnight huddle. So I show up, everybody's around, nobody's talking. Guys, what is this, the overnight huddle? Well, okay, who's got the sickest patients? What's going on? If somebody can't tell us who their sickest patient is, you didn't listen, or you're nervous. Just tell us who your sickest patient is and who do we got to keep aware of. Because if a code blue goes off at 3 in the morning, I should have probably, hopefully, have known about that. And so these things are really helpful. The rounds report, we've actually changed the way we round. We actually didn't use this in our hospital. Some other of the hospitals use it. We adapted it because we allow that local adaptation, because it's got to fit with the culture and what's going to actually happen. And then health literacy. This is super cool, using that plain language. So then we did faculty development, simulation, campaigns, and QI and implementation. We delivered the curriculum to all these people. We had to create all new educational modules and run it through them so that they understood what was happening. And we had, this is an example of the team of content experts. This is what I find really humbling about this work is there's all these people doing all these amazing things. If you get them in the room, they're the experts to be able to define what this should look like. And one of the things, and I don't think it says it, it'll say it maybe on the next slide, this is an example of one of the iPass organizational charts. This is how we operate our studies. Okay, yes, they're on the phone. We do have in-person meetings. This is just an example of one of the subcommittees, health literacy. If you're going to talk to families, you've got to be able to have anything explained and written at their language. Is there a national group that knows how to do this? Well, there's this agency called the Institute of Medicine, now the National Academy of Medicine. They have a work group on health literacy. They joined our study. Did we pay them? No. Did they work with us for 4 years? Yes. Did they design all of our materials that we use? Yes. Why? I think it's meaningful work. I think people, when they start to think it's going to make a difference, they find that time to do it because they really want to help. It's that meaningful work piece that I think in healthcare is our untapped potential. Here's the example of stuff they said. It's amazing how many times we had to go through iterations of what we would write and how they were training us to write it differently. This is another thing we came out. We came out with a rounds report. It's written at the 5.2 grade level because that's what they said was the standard. And it's amazing if you ever take, Word has this, you can go through and see what grade level you're writing at. It's really astounding to think if I'm looking after somebody, I need to understand where they're at so I can communicate with them about what has to happen. But I'm not always doing that. So a group that helps me to do that gets me there faster. And so these are the rounds reports we actually hand off at all the wards. It actually made it part of the nurse's routine flow. So, hey, by the way, we do something called Family Center Rounds. What is it? Let me tell you about it. Here it is. We'll talk about it. I'll come back. Any questions? Do you guys want to participate tomorrow morning, or do you want to opt out? It's totally fine. It's up to you. But offer that. Tell people that that's what we're doing. This is an example of how some of the other hospitals did it. We didn't quite do it this way, Rena, but some of the other ones did. Caitlin is breathing better. When we listen to her chest, we hear less wheezing and other sounds. Caitlin now gets her breathing treatment every 3 hours. She's on a small amount of oxygen through her nose. When she needs those treatments only every 4 to 6 hours and no longer needs oxygen, that's when she gets to go home. And so we ended up going here, just the 6th grade reading level. Less numbers, less jargon, somewhat less specific information. This makes people nervous in medicine. I'm not giving the numbers. Oh, you know who it really makes nervous? Interns. Because that's what they're supposed to be doing. They're supposed to be showing us their stuff. You know who's even more nervous than interns? Med students. They need a letter. They are working to show us how good they are, and now all of a sudden we're like, take all that, don't talk about it, talk to the parents. Wow, that is hard. And we recognize that. We actually have a study going on seeing how they're doing and how we can help them and adapt this. Because it's hard, but our primary responsibility is we got to communicate with the families. That's why we do this. And yes, we have to educate. Fortunately, I'm not the educator in the room, I'm just a teacher. There is a difference, but there are a lot of educators that are working hard to figure out how to do this. And so, but I don't know if I have results, so it's out for review at a journal. It works. I can say that because it's been presented at a national meeting. Same results as the iPass, about the same magnitude of problems. We'll see which journal picks it up. So we've been really lucky in this iPass. This is that implementation science piece, or what I'm calling care delivery science, the science behind routine care delivery. I'm trying to convince you that that's a thing. Turns out if you do it well, people recognize it. We've been really fortunate, and probably the award that I think was the most humbling was the one by the last one on the bottom. The Joint Commission and the National Quality Forum give a Patient Safety Award every year. And they give it to an institution, they give it to an individual, and then they give it to a group. And so we got that last year. And it is amazing to think that when we just came up with this idea and you just try it, if you just stick with it and bring in some of those pieces, you can hopefully make a difference. Here's another thing we did just to, turns out if you make everything available and free, not everybody does it. Okay? Sorry to blow up the academic model. Number two thing about the academic model, we question everything. And we forget, and then we're going to re-question it. It's really hard for us to pick something up and stick with it. So what we ended up doing was there's all these business opportunities that are coming up and business models and accelerators, right? Venture capital. There's so much money coming into healthcare because money can solve the problem. That's what people outside of healthcare think. We have not figured it out. You guys didn't even know how to hand over? That's pretty elementary. Okay, so they're going to come figure it out. They're going to be disruptors. So we actually put our name in. We actually went to this Harvard Medical School, Harvard Business School Health Acceleration Challenge. We actually have 4 finalists. We actually won some money. So what did? We actually started a business because that's what they said. We got advice for a year from the biz school, and they came and did a case on us. By the way, that's actually kind of cool, the case. Probably one of the few things where I think back, I'm like, oh, people might actually read this and think, maybe we should be able to do this. So we talk about what happened in iPass. But so we started this business. I probably should have had a disclosure slide at the beginning, so I'm going to say it now. The 6 physicians founded a company, and we hired a CEO. Because I work for Intermountain Healthcare and the role I'm in, I have equity, and all my equity is owned by Intermountain Healthcare. So it's awesome. It's great to see how things work. Do I know if it's going to work? I have no idea. But yeah, maybe if you pay $100,000 for something, you're going to pay a little more attention than if it's free. I don't know. But I'm trying the academic route. I'm trying the business route. Let's see what happens. I find this whole journey has been fascinating. By the way, I think this is some of the best science. You're going to hear from Brenda in a few minutes. She's also got this example. Best science. This is the best thing we know. Do you need another New England Journal to say it? Do you need another JAMA article? Do you need another 30 articles? We have $15 million in funding. Are you convinced we might know what we're talking about? Okay, maybe not. But if some of you are, do we need, how are we going to get it to spread? This gets to here. This is actually a true picture of Sanjay, who's in Toronto, the hospitalist, drew it on a napkin, took a picture, and emailed it out. This is actually how we thought about it, the original series of studies. We're trying to change the outcome. It's all in the quality of the sign-out. We call it the shared mental model. That means we're thinking the same way. We don't do that in medicine a lot, and we don't do it across disciplines. But we have started, I'm hoping, a movement to get to that. Here's this context. The noise, interruptions, time, who's in the room, rush, level of focus. This is the qualitative method that started the entire stuff we did. And we just added some science to it and then a lot of work. This is another example of one of our teams. We have these org charts. There are calls that happen all the time that go on for these studies. And this is where I was talking about credit. So it turns out a lot of these people work in academic settings. If you work in an academic setting, you want to contribute to the peer review literature. That actually helps you get your promotion, helps you rise in the rank of academia, helps you show what your success is. This is how we do it. We have who's the leader, who's on the coordinating council, who's on the education committee, who's on the study group. If you list it and you submit it to the journal this way and you PubMed your name, you will show 22 articles, even if you're not the named author in all of them are the first. Why? Because that's how PubMed works now. You just have to tell the journal. I think more people have been promoted off this one study than any other study I know about. People just came in and put their heart and souls and minds into this work. Okay, so I'm just going to end in a couple of minutes. I'll end early to give you guys time between Brenda. I just want to talk a little bit about research at Intermountain Healthcare. So I got here 4 years ago, and after I had done all this stuff, I was actually a little bored. I get bored every few years. And I said, okay, what's next? So turns out I got to go on a sabbatical to Australia. And I was there for 2013, and I learned with my family, so it was actually really awesome. And I learned about the cost accounting. They don't have charges, they have costs. So I actually had this database of 220 hospitals, and every line item charge cost. Like, guys, I had just done this, and I was there. You would think I would have written 100 papers. I wrote the bare minimum. I wrote one. I was the first to look at the data, and I just published on what the cost of complex care kids and adults are in the Australian healthcare system. They had never done it. And then I met with a bunch of people, talked, and I had a great time. Don't feel sorry for me, and you really shouldn't, but it was really good to get a sabbatical halfway. When I got back through my after, though, actually I got a call from Brent James, who said, Raj, why don't you come do this at Intermountain Healthcare? And I said, well, Brent, I've never been an administrator. Like, I'm a clinician and a researcher. What do you want me to do? Well, it's over research. I'm like, okay, well, explain to me how it works. So I'm not going to give you some gory details, but it turns out there's a lot of research going on. It's actually kind of exciting. It's just never been designed from an organizational sense and connected all this way. So there are incredible pieces like the biorepository. Can change the world. Just needs to be designed that way and then connected to the rest of the system. And so there's a bunch of pieces like that. And they're like, here, you got to come here and connect all those pieces. I'm like, okay, hey, Brent, so what's the will of the people? They really want to change this, right? And he's like, oh, no, they don't want to do it at all. They think they're very happy. And I'm like, wait, what? Why would I want to do that? And then he said, well, Raj, what's your vision? You've been running this through Prize. Don't you want to come to a health system and turn on care delivery science? And then I was like, actually, I do. I actually think that's an incredibly worthy cause. Because as Intermountain, if they see this, and we run more projects like this, and you're about to hear from what I consider one of the pinnacle examples, Brenda's going to talk to you about what I call care delivery science. You're not science in a room. You're not science in an ivory tower. You are scientists working with clinicians and operations for years implementing and testing the implementation. So you're going to hear a great example from Brenda about that. That to me, and I'd watched Brenda over a decade and a half going through this as well. In fact, we wrote a grant together. Didn't get funded when we tried, but I just remember thinking, this is what Intermountain's for. We've got all these people. We should figure out how to take waste out of the system, how to deliver optimal quality, how to ensure that if there's a better way, let's test the better way before we say it is. Anybody want to use a Harmonic scalpel on their kids' tonsils next week? Do we ever make that decision knowing that? Shouldn't we? We're a $6 billion corporation. I would think we want to turn that R&D function on. So that's actually why I came to do that. And there had been a ton of research going on all the way back to LDS Hospital. It's why we have the first biomedical informatics department in the country at the University of Utah, because University of Utah and Intermountain people started it. And the biomedical informatics professors were clinicians, came over and tested things in LDS Hospital. It's how we discovered some of the things about mortality. Stick to the protocol if you have ARDS, acute respiratory distress syndrome, and you will increase your survival by 40%. Discovered in that hospital up there. Come on. Talk about that's what the research should be about. And there are amazing things happening across the system. So this is where we're going. This is the translational spectrum. Pat Conway, the friend of mine who's now at, was CMS and now is at Blue Cross Blue Shield, published a paper in JAMA in 2008. I want to work in a system that tests how to deliver high quality care reliably and in all settings. I want to work in a system that has measurement and accountability of healthcare quality and cost. I want to work in a system that looks at the implementations of interventions in the healthcare system redesign, the scaling and spread of effective interventions. Why was it published in 2008? Because that's when the Affordable Care Act came out. This was the idea. I just happen to now work in a system that wants to try it. So this is why we exist. And by the way, why? Guys, it can be very clear. We're paid this way. 40 cents on every dollar is keeping people out of the hospital. Here's what I don't ever want to be accused of. Well, you did it in a way that compromised our quality. Nope. Nope. Intermountain, 1975. Church gives, the church that makes the commercials that make me cry, 15 hospitals to the community, not run by the LDS church. Be a model health system. That means something. We can do that. This is the way research was. It's still kind of that way, although we're getting there. Clinical programs, researchers, the Office of Research that I oversee, data, people from all over. This is what we've been testing. How do we do it here? Took one clinical program, made everybody embed it together and start these system-wide projects to evaluate it. We're still there, so I don't know. It's hard. Wow. It was awesome. I will say this. The clinicians and the researchers, I met with them, Todd and I met with them every Friday for 8 months. We wouldn't let anybody else in the room until they picked their final projects. Had to be system-wide, could not be anybody's pet project. I don't care about funding. We actually funded these projects internally because it's got to make a patient outcome difference. And we're going to track it, and we're going to track the costs too. Why? Because we can't pay for everything. We've got to figure out what that return on investment is. And so we're trying it. It's really hard to do, but it seems like something a system like this would want to do. So are other people doing this? Yeah, Tracy Liu, Richard Platt. They call it applied research and development. That term does not resonate for me. I call it care delivery science because I actually think that's what it is, the science behind care delivery. This is an example of one of the projects we funded. We're taking this tool, a computerized decision support that's been shown in 4 hospitals. If you deploy it in the ED and you use it, you can diagnose pneumonia better, you can get better drugs, and you can lower mortality. Okay, wasn't a randomized controlled trial. It's not that I'm not a fan of randomized controlled trials. I just know not everything can be done by a randomized controlled trial. That's my issue. Let's do it if we can. But if we can't, I don't want to say I'm never going to change practice. So turns out it worked. So then what if you did a stepped wedged study in 20 hospitals, 20 EDs using this? That's what we're trying now. We're not that far along because we're still in the iCentra of optimizing the tool. But once that tool is optimized, we should launch this study. We'll see. We'll figure it out. Intermountain has redesigned. I think Intermountain really wants to have this structure to figure out in the hospital and in the community what's working. Why does this matter? Guys, this for us, it's our financial livelihood. Mark Harrison can count the $900 million he saved for the patients in our not-for-profit system. He can say he gave 150% back of our profit margin back to the community. And as Brent James and Greg Polson wrote, The Case for Capitation in Harvard Business Review, fascinating article, Intermountain's at this. Is everybody at this? No, I get it, that's us. But we think we've got something here to try. And this is why we do things at Intermountain Healthcare. I think that talk that Brent inspired me to change my career, move my family, try to be a successful investigator in a field that had yet to be defined. It's actually pretty fun, and it's pretty cool. And I actually think this learning health system that the Institute of Medicine has talked about, I think there is a way to do this. So I just want to thank you guys for your time, and it's been fun speaking with you.